a request to talk about sort of bipolar disorder medications, and I have tried to put together as simplest of ways that I can to kind of describe this. I think for me, I sort of have a passion for mood disorders and bipolar disorders, so this is a nerdy area for me, but I think from a pharmacological standpoint, this is some of the most complicated sort of nuanced details. And so I'm going to try to make it simple, but please, as always, kind of interrupt me with questions. And I also hope for those of you that aren't prescribers on here, because I know we have a lot of therapists, how important sometimes I value and need the therapists that see people far more often than I do to sometimes update me regarding some of the complicated phases of these mood symptoms. So it really can be enormously helpful and just sort of collaborative care to really care for people, because as we'll talk about, most mood disorders are very episodic, and I may see a patient in depression, and potentially they could flip into mania at a different encounter. And that information could be really, really important because these illnesses have different phases. So we're going to go through the definitions of depression and bipolar disorder super fast and really focus on this concept of phases of illness and sort of the lifetime cycles or phases that people have had, and sort of separating out which medicines target what symptoms. And if we have time, we'll talk a little bit about side effect monitoring, because most of the medication for bipolar disorder, unfortunately, has incredibly high burden of medical monitoring and side effects that make it challenging. So these are the DSM-5 disorders that are linked to depression in some ways. And you can see there's a lot of different labels here. Major depressive disorder is by far the biggest, and I think some of you have certainly seen this before. So it's 5 or more of the following symptoms, plus either depressed mood or anhedonia, loss of interest, over a 2-week period. And this is the mnemonic that a lot of our students remember for the symptoms. It's SIG-E-CAPS. So asking about sleep problems, decreased interest, problems with guilt, low energy, concentration, appetite, psychomotor slowing, and suicidality are sort of those key symptoms. And so with bipolar disorder, bi meaning two, pole meaning different poles, really what the difference between major depression and bipolar disorder are, and it's important to recognize you cannot have both. If you have ever had either a hypomanic or a manic illness, your diagnosis immediately becomes bipolar disorder, okay? Most people in my world, because I see adolescents, will often have their depressive episodes or many depressive episodes before they may ever show signs of mania or hypomania. Once hypomania or mania emerge, the major depressive disorder diagnosis goes away and they get a bipolar disorder diagnosis. But you could still have bipolar disorder depressed phase if they return to depression. I hope that makes sense. So it's the presence of mania or hypomania that signals that change. And there's a difference between mania and hypomania that we'll talk about, but mania is characterized by 3 of these symptoms, or 4 if your mood is irritable. So the core issue with mania is that you have a big, expansive mood or an irritable mood. And the 2 big things that really have stood out as you've looked at all these things are a marked increase of energy alongside a decreased need for sleep. So it's both an elevation of mood and energy kind of occurring in time together cyclically. That's a very identifiable feature from other symptom categories, because as you look at this, you can certainly see that some of this stuff, like problem sleeping or being talkative or flight of ideas, can overlap with so many other diagnostic criteria. And this irritability is one of the words I always give people a lot of caution about using, because irritability is such a vague term that when the irritable mood is present, you really have to look for these other things, because just about anything in psychiatry can cause an irritable mood. ADHD does that, anxiety disorders do that. You have to be cautious with that term and really look for some of the more distinguishing features. And we tend to call the distinguishing features sometimes the cardinal features of bipolar disorder, and they are the things that make it really hard to have overlap. So when you really truly see a decreased need for sleep, like this person is getting by, functioning, being successful on like 4 or 5 hours a night when they normally need 7 or 8, it's truly remarkably that they aren't even missing it or tired. There are very few things that do that. So that is one of the cardinal symptoms. We see a lot of people that are talkative or pressured when they're anxious or with ADHD, but this is an intensity so significant, sometimes you can't interrupt people. And then really high risk behaviors. And these aren't mild indiscretions, but things that are really over the top, almost looking grandiose, can be quite hard to replicate in other things. And so the mnemonic for the mania is dig fast. So distractibility, indiscretion, grandiosity, flight of ideas, activity, increase, sleep deficit, and talkativeness. And there are several different categories of bipolar illness. I'm going to show you a picture here that is confusing, but I hope helps illustrate how much these overlap. So down here at the bottom is a major depressive episode. And if we pull out the yellow line here, you see that in unipolar just major depression, they may have like some normal mood or a little above normal mood, but they're not getting up to mania or hypomania, but they're clearly getting into a deep, clear depression. And this is time on this axis, okay? And they may have recurrent depressions over a lifetime, but they've never declared hypomania or mania. If you look at the blue line, that represents what we call the classic bipolar type 1. And that's at different phases, you have a depression. And then at some point, they might have euthymia, which is normal mood, and then a clear period of mania. Bipolar 2, which is sort of like the lesser version of bipolar disorder, really does not have a full episode of mania. It has hypomania, which we're going to talk about in a minute, but it's a shorter, less intense period. It's 4 days or less, and doesn't cause a level of severe dysfunction. This can be incredibly difficult to see. And this is often something that when people are truly in hypomania, they feel good and it's noticeable, but it's not dysfunctional. So they usually never seek help when they're hypomanic. They will seek help when they're depressed. So you have to really dig and look for sometimes warning signs that this is not just a simple unipolar depression, that maybe there is these brief elevations. Because if you have a diagnosis of bipolar disorder type 2, it really does change treatment plans with medicines pretty substantially for some people. Cyclothymia is more of a less defined disorder. I'm not going to go into that one, but that's where you kind of have small downs and small ups that somewhat cycle. So the difference again between mania and hypomania, and this is what is challenging sometimes to elicit, and sometimes if you meet someone new, it's very hard even sometimes to elicit because they don't remember it very well to report it. And sometimes you really need the help of collateral or loved ones to kind of look for those things, or at least have some tracking that you might do over time to see it. But mania is clearly something people see on the outside. So this is greater than a week of significant elevations at one point in their lives of decreased need for sleep and that full dig fast criteria. Hypomania you may not see. They're not impaired, but they feel different. There's a distinct change in how they're functioning, but they're not impaired and they're not getting in the hospital and they're not psychotic. I didn't mention that, but you can develop psychotic features on either end of illness. You can get psychotic features when you're depressed or psychotic features when you're manic. But they've described this. And as I said, usually people are not coming in when they're hypomanic asking for help. They're coming in when they're depressed. And often depression is much more pertinent and seized. The other thing that's really challenging is something called a mixed episode. And this is really complicated and sometimes actually worsened by pharmacology. And it's really something to be aware of. And this is where you actually, for at least one full week, the patient is literally describing all of the symptoms of depression and mania at the same time. And that's called a mixed episode. And people can look really sick at this point and are reporting both fatigue and not ability to sleep. And it's very, very tricky sometimes to tease that out. And they'll look agitated, but they're depressed and they're reporting everything. And it can be really overwhelming. And data sort of shows that probably 40% of bipolar patients will probably have a mixed episode at some point in their illness. And this is, I often find that I see mixed episodes more that really trigger some significant change in pharmacology, because sometimes it's maybe been exacerbated by a sleep deficit that they tried to stay up all night, or a substance use disorder that got re-triggered and they've been using something, or often sometimes pharmacologically an antidepressant has triggered some mood destabilization. And again, here's just a little bit of a difference between that bipolar 1 and bipolar 2. And then this slide, I realize is hard to read, but when we list diagnosis, you can have a lot of specifiers that happen. So you could have bipolar 1 with anxious distress. You could have bipolar 1 with mixed features. You could have bipolar 1 with rapid cycling. Rapid cycling means that over the course of a year, this patient has clearly had 4 more mood episodes. Maybe it's 4 depressive episodes, maybe it's 4 manias, maybe it's 2 depression to me, but there was clear spacing in different cycles between those episodes. So this is not the same thing as mixed. With mixed, you have both symptoms at the same time. With rapid cycling, that's a year-long designation of multiple distinct and discrete episodes. You can have atypical features where you see more appetite or weight gain and sleeping too much and a sensation of feeling heavy, as opposed to the more classic dysphoric depressive symptoms. With both the depressed phase and the manic phase, you can develop psychotic symptoms, you can develop catatonia, and you can see seasonal patterns with both mania and bipolar disorder. Making the diagnosis of bipolar disorder is pretty challenging. Certainly when you've seen someone only with depression and they have hypomania, which they often don't present with, one of the biggest overlaps is recurrent major depression that you're not sure if they're maybe bipolar and you've missed it, like bipolar 2, and you're just seeing the depressive episodes, or maybe it's a severe recurrent depression that's not getting better. But because so many things overlap, it really is sort of one of those timelines that you have to follow to get it right. And certainly periods of intoxication, substance use, ADHD, personality disorders, especially borderline personality disorders with the mood fluctuations that occur can really overlap. And then PTSD, stress disorders, anxiety disorders can all look like bipolar disorder at various points, and comorbidity is common. So it could be very possible that you have multiple diagnoses that fit by criteria. And treatment can include psychotherapy, medicines, and other somatic treatments. And there's a lot of literature with mood disorders about sort of the importance of stabilizing stress and cortisol, because cortisol can certainly drive mood changes and cortisol can be decreased by diet, exercise, light, and this idea of when people are not sleeping, really stabilizing their sleep could be a key thing to really stabilize mood as well. So there are a couple different classes of medicines for mood disorders. Lithium is going to be the first one that we talk about. It's a salt mined in the earth for batteries, and just like sodium is in our diet, and so it is an element. We have the AEDs, which are anti-epileptic drugs. So these are seizure medications that have also shown some mood stabilizing properties. And sometimes I think the challenging part is that anytime a new seizure medicine comes out, someone thinks that they're going to try it and maybe help mood disorders. And so there's a lot of AEDs out there, but sometimes very little data or evidence base about their role in mania or depressed phase bipolar disorder. Then we have atypical antipsychotic medicines that are the traditional ones also used in schizophrenia. And as a general rule, although we'll talk about some differences, all antipsychotics are also mood stabilizers. And most all are pretty good anti-manic agents, but not all are very good antidepressants. There is a lot of debate, and this is really, I just split almost a third, and a third. There's a lot of debate about the use of antidepressants in bipolar disorder. And as a general rule, probably should avoid antidepressants in anyone that truly has had bipolar 1 disorder and those classical big ups. You also generally want to avoid it in patients that have had marked rapid cycling, those 4 episodes a year, or that mixed state, because antidepressants can agitate people and cause some degree of mood destabilization in some patients that can be pretty marked. We do occasionally use SSRIs, SNRIs, or Wellbutrin, which has the lowest switch weight in patients with bipolar 2. Because remember, patients with bipolar 2 have not had the really big manic ups. They've often had many more periods of recurrent depression with some hypomania, and there's less risk of destabilizing that. But again, it's still part of the caution. And there's some debate even with bipolar 2 about there are occasionally patients that are just on antidepressants and doing okay in bipolar 2. And it's like, well, do they have bipolar 2 or is that recurrent depression? It can be a big part of that debate diagnostically, especially if you don't have really good longitudinal mood data. The challenge in the medication part is understanding this idea of phases of illness, because different medicines have different properties. Some are better at treating mania, some are better at treating depression, some are better at maintenance, some are better for mixed states. And so you're trying to gather as much information about lifetime phases. How many depressive episodes does this patient have? Have they had a mania or a hypomania? Have they had multiple psychotic features? Have they had problems more with mixed state or more classical features? Or are they more likely to be a rapid cycler? Because all of these medicines have a little bit of different characteristics that may target different patients. But the real challenge is that you may have to change a patient's medicine in different phases of illness. If I have a patient stabilized with recurrent mania and they're doing great on an antipsychotic that prevents their mania, but they come in depressed, I probably have to change it if their medicine isn't covering the depression. So really thinking about knowing what the person looks like over time and space, but also really knowing what their main symptoms are right now may guide therapy. In an ideal world, we want everyone to take their medicine every day and keep them in maintenance so they never have an up or a down. And that's really the goal, so that we find the lowest dose of monotherapy agent that keeps them in that stable range. But there's lots of challenges to this. Certainly compliance, not being able to fill prescriptions, not liking the side effects of things, thinking they don't need it anymore. It's challenging sometimes to maintain some of these medicines because they're not, the medicine may not be helping someone feel better at the time because they feel good. It's helping them prevent a future mood cycle, which can be a harder sell for some patients. This is particularly challenging in pediatric patients because they want to believe that they've outgrown it. And there's some data that can help kind of guide you a little bit about that. Again, this is just kind of rule of thumb sort of information, but generally speaking, if you've had one depressive episode or one manic episode, you have about a 50% lifetime risk of having another. Once you've had 2 episodes of an illness, that risk goes up to 75 to 80%. Once you've had 3 clear mood episodes over your life, the risk of having another one is almost 95+%. So it's really unlikely, I think, when you've gotten to 2, that you can really tell someone they can probably come off. The challenge is you don't know when that recurrence will occur, and it doesn't usually occur right when they stop the medicine. Sometimes it's a recurrent risk within the next 5 years. And some of it determines how sick they were during the time of the illness, and you end up doing a lot of education with people about self-monitoring and their loved ones about some of those symptoms to hopefully catch them before they get out of control. You know, this is complicated, and I just will sort of sum it up best that the DSM-5 is really the best that we got. It's research-based, it's evidence-based, but it's got lots of limitations. It's really a cluster of descriptive symptoms that really have to be thought about. And if you take all those examples of like major depression with all the neat profiles someone could have to meet criteria, you can have 16,000 different presentations of it. And so people present with very different presentations. And a big limitation of DSM-5 is it doesn't describe causation. And so, you know, if this depression is caused by substance use, or this depression is caused by genetics, or, you know, it's not like that. It's not linking directly to brain pathology in any direct way. And so they become very unclear boundaries diagnostically with some of these other things like schizophrenia, personality disorder, anxiety disorders. So, you know, we do our best, but most of the time patients don't always fit a neat, clean picture like that to just remind people of. Okay, so going back to sort of idea, we need to understand what someone's phases of illness are. If we had a patient that had multiple recurrent type 1 full-blown mania, these are generally the medicines that treat acute mania, okay? So lithium, Tegretol, Depakote, which is Valproic Acid, Tegretol is Carbazipine. I'm sorry, I should have put the brand names, the generic names on here as well. And then generally all antipsychotics have some anti-manic ability. Medicines that help with the depressive symptoms are much more rare. And there are a lot of medicines that help treat mania, but don't really demonstrate a lot of evidence for a depressed phase of illness. And in an ideal world, you would want a medication, a monotherapy medication, if you can, treat as many of the phases as you can. But sometimes that's tricky. And so this is currently the list of FDA-approved medicines that will assist in the depressed phase of bipolar disorder. And it's really short. And the last 3 on here are crazy nuts expensive. And Alicia's on there. She could probably testify. These medicines are super duper expensive. They you know, they're being marketed right now. They're recently pretty new to some of the indications, but they really are filling a market gap that has existed for a long time that we just did not have as good of medicines for the depressed phase of illness as we did the manic phases of illness. And so emerging are some new opportunities for people that hopefully will continue to be pretty promising. But this is why so many people have had to add antidepressant medicines or things to depressed phase, because treatment hasn't been as easy. Okay. So let's talk about each medicine super quick, but I'm gonna pause and just see if there are any questions about this idea of the phase of illness. Okay, so lithium is one of the medicines that really is the oldest medicine. It's a salt. It really is for type 1 bipolar disorder, is still probably the gold standard for bipolar 1. Although because of some of the lab work monitoring and some of the fears around lithium, it probably doesn't get utilized as much. And one of the interesting things that's happened, at least in my career, is lithium used to be dirt cheap. But now with technology and all the mining that's happening with lithium, the prices have been much more challenging, and lithium supplies have diverted to things like batteries and technological things that I think it's been a little bit more challenging sometimes to access lithium at times, but still an excellent medicine. And it does seem to treat all phases of illness and prevent relapse. And one of the things that is well known, that bipolar 1, in comparison to some of the other disorders, has one of the highest risk factors for suicide completion in psychiatric populations. And so lithium and clozapine, which is an antipsychotic medicine used in refractory schizophrenia, have had some data that show that it has more data in some populations to prevent suicidal completions. And so sometimes in patients with a lot of recurrent suicidality, we think about using lithium. And lithium can also be added, and this is sort of an aside, but sometimes we add lithium to just major depressive disorder as an augmenter. They may not have had any mania or hypomania, but because of some of the anti-suicide effect and some of it has some data as an augmenter for just major depression, you'll see it used. So usually lithium really presents in is a good choice in patients that clearly have that classical picture. They've had distinguished episodes, less mixed episodes. They might have bipolar depression, clear mania with clear separated times. They are not rapid cycling. They do not have mixed episodes. And lithium tends to be better in a little older age of onset. In pediatric patients, because there is such a high risk of mixed episodes and non-rapid cycling and this sort of adolescent sort of complex mania, antipsychotics have done better in adolescents with acute mania than lithium, if they really truly have not had the clear episodes. So a little older age of onset. And family history of response is really important too. So you see patterns run in families where everyone in the family has had a good response to lithium, and that may be very, very helpful. Lithium requires a lot of monitoring, which again makes it a little bit challenging. And of course, with monitoring comes challenges with compliance and costs and access, but we really have to monitor the kidneys and electrolyte status, because your body handles lithium just like it handles salt. So if you get dehydrated, the lithium level can go up, or if you're peeing too much, you'll pee out the lithium with diuretics. So, but the level is really challenging. And if the level is too high, it can be life-threatening as well. And so lithium, although it may prevent suicidality, can be lethal in overdose. Especially if like renal function bumps up. There's a risk of something called Epstein anomaly that's specific to lithium in the first trimester of pregnancy. So that is monitored. It's pretty rare. And so sometimes lithium is still maybe indicated in pregnancy, but sometimes especially in the first trimester, change to antipsychotic might be indicated. Vital signs, and then lithium can cause weight gain, so it may need some monitoring. In long-term use, lithium can impact kidney function. You can have a risk of diabetes insipidus, and so there are some long-term hypothyroid risks with it that need monitored. And like everything, kind of start slow. And with lithium, we're really trying to get to a level. And the level for the patient is the level that gets them to euthymia. And we have some guidelines on what that is, but when a patient really is euthymic, it's important to know at what lithium level they're maintaining that, because that may be part of what's going on. Whoop. There again, this also in young people can worsen acne and skin rashes like psoriasis. If you have your lithium level kind of too high, it can cause a lot of nausea, vomiting. People can get tremulous and feel pretty yucky. I don't know if I put the, oh, there it is. So generally speaking, the level for acute mania is to get to treatment levels, usually somewhere between 0.6 and 1, okay? And we usually shoot for maintenance if it's used as a monotherapy agent from 0.6 to 0.8. Now, lithium has some sort of properties that they will often call sort of like neurostabilizing properties or neuroprotective properties. And so they've even done some research with like stroke recovery and regenerating neurogenesis with low dose lithium, but those are often at very, very low levels, like 0.1, 0.3. When you add it for unipolar major depression, not mania protection, sometimes we target closer to 0.3, 0.4, 0.5. Again, sort of in response to how the patient is doing and if they're reaching euthymia. And then we monitor this every 6 to 12 months. Now, lithium is one of those medicines I just tell people, any medicine you're on, any over-the-counter stuff you take, we really need to check. Because anything that could inhibit the processing at the kidney could potentially affect the lithium level, either making it too low that puts you at risk for relapse, or too high, putting you at risk for that intoxication. And some of the really big medicines that really impact that are the diuretics, that can be blood pressure medications like hydrochlorothiazide, ACE inhibitors, which are a blood pressure medicine that affect angiotensin, NSAIDs, which are non-inflammatories. And these are things like ibuprofen, over-the-counter things. And so I tell people to be very cautious with taking ibuprofen if they're on lithium. Now, one dose here and there for headache, probably not so much of a problem, but recurrent and non-inflammatory use can really sort of drive up, affect glomerular filtration rates at the kidney and really drive a level up. And I had a patient that got toxic. I can't remember what his injury was, but he had a orthopedic injury. And I was in residency, and they were trying not to give him opiates, and were giving him these high dose, and didn't realize what it did to lithium. And he ended up severely lithium toxic and needing dialysis because he started taking these recurrently. So this can be pretty significant. And so just really tell people to be cautious and double check, and let's ask the pharmacist and run all these things. So it's just one we're a little extra cautious with. Probably psychiatrists pretty overly cautious sometimes with all that, but it's really can be quite problematic. Okay. So divalproex or valproate or valproic acid is also a seizure. This is an anti-epileptic drug. This is kind of a broad spectrum, hits a lot of different channels like sodium and calcium in the brain. And it has better data for mania. And it sort of carries a little bit of a more specific sort of indication for more mixed episodes. And those folks that have had multiple episodes with rapid cycling, because it has better protection of protecting the upswings. Because it is such a globally sort of across the board medicines across these channels in the brain, and it actually has fairly high GABAergic activity, and GABA is sort of the inhibitory sort of neurotransmitter that sometimes that is what alcohol increases, and that increases in GABA can help anxiety. So it also kind of has a lot of other things that it's used for. So in a patient with comorbid alcohol use, to either protect against seizure withdrawal from alcohol use. It has some data on impulse control aggression in kids. It has some data on aggression and conduct disorder. Because of that GABAergic sort of effect, some people report some anti-anxiety effects. It can be used for migraine prevention, and it's fairly sedating, so it sometimes can help stabilize that sleep part. It also requires a fair amount of monitoring. You need some blood counts. It can cause some effects on platelets and sort of decrease some of the production of hemopoietic cells, so white and red blood cells. It's predominantly sort of processed through the liver, so you have to check liver function. And we also try to target a level, although most of the data for the level in the valproic acid is actually more linked to seizure disorder threshold than true mania potential. But again, sort of like lithium, when someone's euthymic and this is the level that's helping maintain them, that information can be really, really helpful to know. And so you check this level at 5 days with a trough, so at the lowest point between the before the next dose. This medicine does have some really substantial risk. It is one of the highest risk medications in pregnancy, the risk of neural tube defects, and usually that risk occurs before someone finds out they're pregnant. So it is really, really risky, I think, to put a woman on valproate without birth control and a lot of prep, and often, and this never happens this way, but in an ideal world, you would take them off valproate and try to find something else before they got pregnant. That risk is so high. There's some data where you can give high doses of folic acid to prevent maybe some of the neural tube effects, but it's pretty substantial. And in kids, early in utero Depakote exposure can cause pretty profound cognitive effects and IQ drops in the children. So it's a pretty impairing effect. And it does worsen polycystic ovarian syndrome and should really be avoided. And so I've had a few females I've put it on it, but I really do tend to avoid this in females that are at risk or want to be pregnant anytime soon because it's challenging. It also has some weight gain metabolic risks and requires vital sign monitoring. The dosing of this is 250 twice a day or 3 times a day. There's some studies we used to be able to load it IV to get the level up or give a higher dose, but you're really targeting at about 5 days, somewhere in this range, again, when you start achieving euthymia. This is something I remember that I think is really important. You know, nobody likes to take a 3 times a day medicine. And so they do make the valproic an extended release, but you actually have to give them a higher dose because it's not as bioavailable. So if you can, I've seen people relapse with that conversion. They've switched them from the shorter acting form to longer acting form and didn't increase the dose. And it's about 15% less available than the immediate release. So it does actually require a slightly higher dose. Maybe Alicia can verify that number is right, but it's really important that when you do those formulation changes that you check the level again. Another anti-epileptic medication is lamotrigine or Lamictal. It is really the one that has the indication more for bipolar depression. This medication is not very good as an anti-manic agent, but it really is helpful in patients with more of the recurrent bipolar depression and can be added on to things as well. But it will not help you if you're truly manic and you may need a secondary agent. The beautiful, lovely about Lamictal is it really doesn't require laboratory monitoring and does not have weight gain, which are huge to patients. And so patients really like this. This is a really hard medicine to get to the right dose, though. You have to go extremely slowly. The real reason for that is there is a risk of a Stevens-Johnson syndrome, sort of dangerous rash that can occur usually at the start and during titration at highest risk, but could really occur anytime. And it's a pretty painfully slow titration. You start at 25 milligrams for 2 weeks, and then you go to 50 milligrams for 1 or 2 weeks, and then you can go up faster, but you're sometimes targeting doses of 150 to 300. So, you know, and to get someone up to a dose may take 2 months, and it's slow. And then if you have someone that's not compliant and they miss 3 or 4 days, they actually recommend you start over again with the taper because of that rash. And so that can be really challenging to someone that has trouble with compliance. And there are some marked warnings about combining Lamictal with Depakote. It's complicated. You have to lower the dose so they don't interact. And I don't know that off the top of my head. I always just look it up because it's, or ask for help because it has some very specific things. Carbamazepine or Tegretol is an old school anti-seizure medication as well that has also had data for acute mania. Its monitoring is pretty similar to Depakote with the CBC LFTs. It also requires some renal function. You start at 200 milligrams. You can divide it twice a day and titrate up usually to 800 to 1,000 milligrams. This is a medicine where it actually auto-induces its own metabolism as you go up on it. So as you take it, it will speed up its own metabolism, the level will drop, and then you keep going. So it can be a little bit complicated with the level. It again has a level for seizures, but we tend to use the 4 to 12 range to again see where they are. If they're euthymic, and that one also is checked at a trough at 5 days. So everything with mood stabilizers are like, well, a new anti-epileptic comes on the market. Let's see if it helps bipolar disorder. And so you'll see, I've seen every one of them tried. And again, I think sometimes the receptors that they hit cause other sort of psychological thoughts or feelings or impulse control things. But the data on other mood stabilizers for depression or mania is actually pretty darn limited. So pyramate is one that does have some psychiatric indications. We actually use it for headaches or for binge eating. It has some data for impulse control and tic-like behaviors, but actually very, very few data studies for mania. There were some open label studies that thought maybe it would help and add on to bipolar depression, but this is a little bit weaker in the data. Neurontin, gabapentin was used a lot in the past. And again, it has some data for anxiety disorders, especially in Europe, and comorbid pain, but not much for acute mania. Oxcarbazepine is kind of like a Tegretol without lab work in how it sort of works. It also doesn't really have any randomized controlled studies, but there were some studies that maybe showed completely open label that maybe it could be monotherapy or add-on for refractory mania, but not super strong. And then tamoxifen, I don't know if anybody recognizes that. That's actually a anti-cancer agent that they use for breast cancer. It actually had some 2 positive studies for mania and just some case reports, and this is sort of via its protein kinase C mechanism. So there is some data there, but you know, this is probably stuff you do when other things have failed because it's just not very strong. And then again, just sort of a review of the side effects with these medicines. Next are sort of the atypical antipsychotics. Again, these are some of the medicines, just to remind you, atypical antipsychotics are very complicated. They can sometimes be used for mania and then some for depression, but they also have some indications like for autism, aggression, irritability, and schizophrenia, because they all are antipsychotics and can treat psychotic symptoms as well. So there's kind of a list with their names. There are lots of studies about these medicines. And it said they are all generally pretty good for acute mania, although there are many more that have more specific indications for that. This is the area where, again, it's a much stronger, smaller pool. So it's this olanzapine, Zyprexa, Prozac, fluoxetine combo. This is Latuda, lurasidone, and quetiapine that carry more of the data. And then recently this Catalpa, Catlita, I can't pronounce anything, and Vraylar have entered the market recently as newer agents that have some depression effects. Some of the good news with this class of medicines is that there are several long-acting injectable forms of some of the antipsychotics. So although we traditionally think of long-acting injectable medications for patients with recurrent thought disorders, patients that have had multiple recurrent manias may also benefit from long-acting forms of these medicines. And then there are the more typical older generations of antipsychotics like Haldol, Prolixin, Haloperidol, fluphenazine that also have some anti-manic effects. And these also have a lot of side effects that require monitoring: weight gain, metabolic issues, the movement disorders like restlessness, tardive dyskinesia, Parkinsonian stiffness features, neuroleptic malignant syndromes, very rare, but that's kind of autonomic dysregulation where people get high fevers and stuff, and it's a medical emergency. It can happen in some patients. Dry mouth, sedation, some of the ones that block dopamine really strongly can cause an increase in prolactin, which is what causes milk release when you have a baby. So there are risks of people, especially boys, who've been having breast leakage from some of them. Again, none of that sounds good when you're trying to sell it to a patient. So we have to monitor labs, we monitor weight, EKGs sometimes at baseline to check QTC and movement scales. There are some medicines that can be really helpful as adjuncts or add-ons. So this is that idea of adding to another agent. While it may not directly treat the mania or depression, it can be helpful as an add-on. So benzodiazepines sometimes can be very helpful just to calm down agitation when people are really unsafe or need sleep, or if they begin developing those catatonic features, which are mutism and kind of shutting down. Benzos can be life-saving for those patients. As I said, the antidepressants are quite controversial to some degree. And as I said, there's almost a third split when you talk to psychiatrists about some people will never do this, some people think it's fine. There's a third in the middle that not sure, because there's really this idea that for some patients, and I think it's, as I said, I think there's some patients that are not affected at all by it, but I certainly have seen multiple patients that antidepressants have certainly caused mixed or more rapid cycling. And so generally, you would want to avoid these if there's rapid cycling, mixed state, clear type 1. Interestingly, bupropion or Wellbutrin, which is not really sure how they calculated this, but it was felt to have maybe the lower risk of switching compared to SNRIs and SRIs. And then there's this idea of combination therapy, mixing things. And certainly when people have failed monotherapy, that may make sense, especially if someone's on an agent for mania, but it's not covering their depressive phase, but they're really at high risk. You know, we sometimes will see patients on various different things like an antipsychotic plus lamotrigine, because you're trying to balance that. And sometimes that's indicated. And again, it can get, of course, very, very messy. And then the other part is, in an ideal world, to recognize that sometimes you need different doses for the phase of illness. I didn't put lithium on here, but often to treat mania, you again need much higher doses, maybe in the level, than you do for just depression. And you can see sometimes that you need to lower the dose for depression than you do for mania with some of these agents that treat both. And again, this is kind of back to what we said the first time. These are chronic illnesses, they recur, they have different phases over a lifetime, and you have to both know the patient's history, but follow forward to see. And each episode that someone has is harder and harder to treat and can develop some treatment resistance. And so we do our best to treat completely, prevent relapses, find the medicines with the least amount of side effects that get them to euthymia that they can tolerate, and go slowly. And again, this is back to that risk, especially in bipolar depression and late onset major depressive disorder, some very high risks of suicide completions. All right, I hope that helped make the most difficult medication in all of psychiatry a little bit easier. Anybody have any questions?
Thank you so much, Dr. Swagger. That is a very great presentation, and I can't, thank you enough. You had some really great information in there. So please, anybody that has any questions or comments on these difficult medications or anything they had personally that they can share, please do so. Very quiet. Okay, so with weight gain in these medications, is it why they probably want to put certain ones and mix them? Like, does something like Wellbutrin help with that?
Yeah, I mean, so the data on Wellbutrin, actually Wellbutrin has some data for weight loss. So certainly, like if it's one that can help if they really aren't at risk of having that switch in the oppressed phase, that's certainly one that helps. I mean, the ones that seem to have the least weight gain are probably like Lamictal, not a whole lot associated with that. Topamax actually has some weight loss, but again, that's pretty adjunctive. There are things that you can do, like we sometimes in patients that get metabolic risk, there's some data on using metformin, which is a diabetes medication to block some of the risk, but I mean, it's profound, and nobody, including myself, wants medicines to have weight gain. Some of the newer agents have really gotten down to the manufacturing that those risks are less and less, which kind of makes them unique and less risk of some of the metabolic stuff and how they've been able to bring those to market. But again, they're still very expensive and hard to kind of access. And lots of times you have to try the cheaper ones first, and sort of have a rationale for it. But it is so challenging. Generally speaking, like what is worse? I mean, I think that lithium seems to have less. I mean, it still has weight gain, but maybe less than Depakote and antipsychotics. And there's some like the Lamictal and the Latuda and Vraylar that might be a little lower. But then you see patients that never gain weight on even things like Zyprexa. So, I really just do a lot of education. I tell people if this starts happening, we're going to have to do something about it. I respect which ones they want. I mean, it's hard. I don't think anybody wants to take, these aren't medicines that you want to take, I think. And the other part of it, I didn't really mention, is especially in the early phases of mania, it feels really good. And patients don't want to take medicine, and they stop their medicine because they want that little window where they feel great. and it's before it gets over here, but it does feel good to be hypomanic. And I've heard people say that, but this medicine has so many side effects, it makes me feel cloudy or foggy, and I just don't want to take it. And I want that if I get a little mad, that's okay. But the problem is with brain disorders is when you get really sick, you lose insight and knowing when you have that self-control to stop your medicines. And some people that are more fragile in their presentation can rapidly cross that line before they realize it. So it can be really challenging. And then there are other people that have a lot less frequency of episodes, a lot less. I mean, it's just so
complex.
I mean, so many different presentations. I mean, as I said, I don't know that I've ever heard the same story of depression or the same story of bipolar disorder in patients. It makes it very personal.
Absolutely. Yeah. And that's why you really wrote home, like how important it is to do the check-ins and see how they're doing. And I think, sometimes there are some people or doctors that are better than other doctors at that. I think that's very critical, especially with medications such as these. So I really appreciate you saying that. giving you guys some time to think. Does anybody want to say anything or add any comments? It's a lot of face calling.
I would love to hear how our pharmacists think, because I mean, I know sometimes, I mean, I like look at some of the medicines I have people on, and I mean, I've like gone through it all and can like know how I got there. But I mean, sometimes people are so sick and have had so many recurrences. I mean, I think some of the medicine regimens look nuts until you like know all that story. And I'm curious what other people think.
I think on our end, especially for the children monitoring through the antipsychotic program, we definitely see that change over time. And we may, within that 6-month period, change that 3 or 4 times. And I think especially to monitoring the symptoms with that program, we definitely see some providers are better than others, of course. And especially with the foster kids, and making sure that that continuity of care is there in these transitions to make sure that those doses or the same medications are continued throughout their treatment versus trying something new, or the communication wasn't there from one provider to the other in their transition of homes can be helpful.
Oh yeah, and that's a huge part with, I mean, that's really huge with kids. I mean, I mean, I've had a couple of kids that I have seen diagnosed with bipolar 1 stabilized, and they look fine. They get something else happens unrelated, and the next person sees them has none of that information from anyone. Oh, you don't have bipolar disorder, that was trauma or whatever. And they take them off. And I've gotten calls from hospitals like, does this person have bipolar disorder? Well, yes, absolutely. Oh, they probably shouldn't have stopped the lithium and put them on Prozac because they're totally manic now. I was like, yep. And we don't have a good system of that cross communication when people are jumping in different health systems. And then, you know, that goes along with the illness that having bipolar disorder really with the different phases can cause dramatic shifts in how many different places you may live, or your job stability or your family stability. And so you can get in a cycle, you have to change providers or your insurance or jobs. And it's a lot more instability in those psychosocial aspects of health when your mood's unstable.
Thank you so much for that. All right, any other questions? We're about at the minute to the hour. If not, our next session is going to be occurring on January 19th, and Dr. Lillard will be discussing chronic pain. Again, thank you, everyone. Glad to see you, and I hope you have a great rest of your week.